Good evening, ladies and gentlemen. I'm Dr. Tan. Welcome back to this channel. Today, we are going to learn about point-of-care ultrasound. In short, sometimes we refer this to as a POCUS. Be it POCUS or point-of-care ultrasound is actually one of the most important skill sets in the clinical care for our patients. In our day-to-day practice, we will use ultrasounds, not only for the rapid and real-time evaluations of our patients, but also for procedural guidance. In the past, it may be true to say that ultrasound is a skill possessed by certain discipline only, like the cardiologists, the obstetricians, the emergency physicians, or the NS or the intensivist. In this day and age, this notion may not hold true anymore. This is because of the increasingly availability of ultrasound in most of the hospitals, and also the increased appreciation that point-of-care ultrasounds guided therapies would lead to better patient outcomes, especially in those critically ill patients who cannot be assessed accurately based on our traditional assessments. And it's foreseeable that in the future, ultrasounds will become a mandatory skill set that all healthcare providers should possess. If you are junior doctors, welcome to this video because this video will serve to provide you basic foundations about the use of ultrasounds in the clinical practice. These are the outlines of the lecture today. Total there will be 5 sections. So the first part of the lecture, I'll share with you the different types of machines. Following that, we will learn a bit about ultrasound mechanics. Also, we'll learn about the nomologies of the machines. Last but not least, we'll talk about the most essential part of these lectures, which is to learn about basic ultrasound image interpretations and also to appreciate the clinical utility of ultrasounds in practice. So let's kickstart our lecture by first taking a look at the ultrasound machines, also known as the ultrasound scanner. I think it's obvious from these pictures, ultrasound machines, they come in different sizes as well as different forms. One of the reasons why I put up this photo is because I would like to share with you how the ultrasound design has evolved over time. So as you can see, obviously the piece in the middle is actually the oldest collections in these photos, and then the one on the far right is a bit upgraded one, and the one on the far left now is actually one of the latest ultrasound machines that we have. As you can see, it becomes more compact and more portable. Next, I would like to share with you what a handheld ultrasound device or ultrasound scanner look like. So as illustrated in this photo, this is actually a handheld ultrasound device. Of course, it's so much portable compared to the ultrasounds that I shared with you in the photo earlier. So technically, you just have to connect it into any iOS or any Android devices, then you can start scanning the patients. Of course, there are also other much advanced ultrasound probe where literally you don't even need a cable. What you need is just the devices with the Wi-Fi connections. So next, the golden question is, which ultrasound scanner is better? Well, for me, I think there's no straightforward answer to it. I think ultimately it depends on what is your need as practicing clinicians. Before we move on further, I think it's important to have a basic understanding about how an ultrasound machine or ultrasound probe works. So let's imagine this red circle here is actually your ultrasound transducers, and for your informations, within the transducer, there's actually a piece of piezoelectric material, which is most often made up by the synthetic ceramic materials. So when you switch on the ultrasound probe, this transducer will generate a series of ultrasound waves, or sound waves or echoes, some people call it, and these waves will propagate across the medium that you are scanning. Subsequently, the ultrasound waves will be reflected back to the ultrasound probe. And what the ultrasound probe will do is that they will transform the ultrasound waves into an electrical signal, and the electrical signal will be analyzed or interpreted by the computer's processors based on the amplitude of the signal received, and subsequently it will be projected as a grayscale image as illustrated here on the monitor. Next, we're going to learn about the different types of ultrasound probes that we commonly use in clinical practice. By and large, we mainly change between these 3 probes. So they are the linear probe, or sometimes we call it the flat probe, or the curvilinear probe, or the phase array probe. And phase array probe is actually the most ideal probe for performing the cardiac ultrasound. There are reasons why these ultrasound probes are designed differently. It's not just merely for the exterior outlook, but most importantly is about its functionality. Before I go to each of the probe, I think there are two basic concepts I think each of us should remember. So the first one is that low frequency transducers, they are optimal for visualizing deeper structures. On the other hand, high frequency transducers are optimal for visualizing superficial structures. Now, keeping that in mind, you will understand now why the linear probe, also known as a vascular probe, has the highest frequency, because they are optimal for visualizing superficial structures. As you can see here, the ideal imaging depth is just around 9 centimeters. Any deeper subjects may not be able to be visualized clearly, and also this will really serve the purpose well. For example, it's best used for vascular catheterizations and also to ultrasound patient skin or soft tissues, and also the musculoskeletal structures. Moving on, we're going to take a look at this curvilinear probe. In practice, sometimes we call this as an abdominal probe, because this is the probe of choice for scanning abdominal organs. As I illustrated to you earlier, because of its unique ultrasound frequency, which is mentioned here, 2 to 5 MHz, is best used for visualizing deeper structures, like the abdominal organs for EFA scan or even for the obstetric scan. Last but not least, we are going to take a look at the phase array probe. In practice, again, sometimes we may not call this a phase array probe, we may call it a sector probe in short. And this probe is also known as your cardiac probe, because this is the most ideal probe for your ultrasounds of the heart, or echographies in short. Besides that, it can be used for your lung scan as well. Before I move on to the next slide, I must spend a few seconds here to emphasize to you that all these probes are very sensitive, and they are expensive instruments, they are expensive to repair or replace. Hence, utmost care must be upheld when you are using these machines. This slide illustrates to you two different types of ultrasound probes. What I want to emphasize to you here is the orientation markers. Orientation marker is the first thing that you search for when you're holding a probe, because depends on where you orientate the probe, it will give you different images. For example, in this probe, the orientation markers actually appear like a light bulb, whereas in this probe, the orientation marker actually appear as a strip of gray band over here. Identification of this orientation marker is very important, because it depends on which view of the image that you're trying to get. You have to orientate the ultrasound markers correctly. For example, if you're trying to get a transverse view of the organs, your orientation markers will be pointing towards the patient's right. On the other hand, if you're trying to get a sagittal view of an organ, for example, you're trying to scan the patient's inferior vena cava, the orientation markers will be pointing towards the patient's head, or pointing cathalically. Another very important aspect is about the transducer's manipulations. I think this will be best learned when you are doing it yourself, and it's beyond this lecture to show you how to manipulate the ultrasound. But anyway, I have included video lectures at the end of the video description where you can refer to that. But I strongly recommend you to practice it. As you know, it's a bit hard for you to imagine by just watching the videos. It will be best for you to practice with someone more experienced. Moving on, we are going to learn some basic skills on how to interpret an ultrasound image. As you can see here, this image is actually monitors showing the objects that you are scanning. So on the far left here, normally you have this scale. We call this sector scale. So here you can see here is a 0. 0 is actually at the most superficial level, so where you place your probe here, and then 0 to 15. 15 is the maximum depth that you are looking at right now. So actually it correlates with the depth you are scanning. So a lot of times it depends. If you really want a very accurate measurements, you can use the measurement functions to measure the object. But a lot of time, roughly from this scales, you can have quite a good gauge about the size of the objects that you are looking at. This is a very nice image to illustrate to you about patient's inferior vena cava. You can see here the inferior vena cava is connecting to the patient's right atrium, and this is the levels sitting on top. So that leads us to the reporting terminologies that we commonly use when we are reporting an ultrasound image. For structures that appear as a black, they are normally blood, bile, or urine, or etc. So such objects, they literally transmit all the sound waves without any reflections. Therefore, it appears black. So in the ultrasound term for this, anechoic. On the other hand, hypochoic refers to structures that reflect relatively sound waves and appear very bright. In the non-medical term, it means bright, but in the ultrasound terms, we call it hyperechoic. For examples, the vascular walls or the diaphragms or the pericardial of the heart, it will appear hyperechoic. And hence, I hope you can take your time to read about the definitions of these different terminologies we are commonly used during the reportings by our radiologists as well. This will be a useful mnemonics for beginners who would like to remember the echogenicity of some of the important structures in the abdominal organs. It may appear very daunting when you first have a look at these ultrasound control panels, because there are so many knobs there. There is even a keyboard, sitting there, and there will be this, sliding bars or that. But don't worry, because in practice we don't actually have to use all these knobs or these sliding bars or that. So the most commonly used functions will be the gain function, the depth, the freeze functions, the measuring functions, and also two modes that we commonly use will be the B modes and the M modes, and also the Doppler modes if you are doing a vascular scan, or you are doing a cardiac scan when you want to see whether is there any any shunts or what. Now let's focus back on the theoretical part, because I believe that the practical part will be better left to the practical sessions. So now I would like to illustrate to you how inferior vena cava will look like. I believe that as a junior doctors or a house physician or medical officers, a lot of time when we scan, the first questions that the clinicians or even a consultant asks is what's the IVC? So what is IVC? It's actually inferior vena cava. So this is the most optimal image that you can get, which show you nicely the diameter, the whole length of the IVCs that connect to the right atrium. The visualizations of inferior vena cava is very important in clinical practice, because it allows us to gauge the patient's fluid status through direct visualizations of these IVC. So by measuring the IVC, you can have an ideas about the patient's estimated central venous pressures. Just a little bit about the past practice. I think last time, before ultrasound was prevalent, or before the advent ultrasounds, in order to gauge a patient fluid status or fluid responsiveness for those patients who are critically ill, most of the time the patient will require placements of a central venous line. But however, now since the availability or the advent of the ultrasound machines, I think placement of the CVL to measure a patient's central venous pressure has become a thing of the past. On top of giving us an idea about the patient's fluid status, the measurement of the IVC sometimes could be useful in certain clinical circumstances, like for example in deciding the device placements, or sometimes for us to determine the tamponade physiologies. Before we move on to the next slide, let's spend a few seconds to learn about some of the pitfalls or caveats in these IVC measurements. In practice, the best place to measure the IVC diameter will be like 1 centimeter away from these atrial cava junctures. And also when you are measuring the inferior vena cava, please make sure that your probe is actually in a perpendicular positions towards the IVC. This is because there is a phenomenon that we call the cylinder effects. So as you can see from this picture, right, it depends on how you place your probe. If your probe is a bit, not perpendicular to the vessels that studies diagonal, you tend to get a smaller diameter, which is actually false diameters. So you must make sure that directly perpendicular. Most of the times I will try to fan the ultrasound probe to get the best size that I can get. This slide shows to you that the IVCs is being visualized in two different modes. So on the left hand is actually the IVCs visualized in the B modes, whereas on the right side is actually the M modes, also the motions modes. In practice, most of the times, the collapsibility of the inferior vena cava can be easily told by just eyeballing. But if you would like to get a more accurate assessments of these IVC collapsibilities, you can actually visualize it under the N modes so that you can report the collapsibility index in your report. One of the common questions by beginners or junior doctors would be, what would be the normal IVC size, since its measurement is so important? Well, actually it depends on the patient's age as well as the patient's body habitus. But by and large, I think in the normal adults, the IVCs, most of the time it won't be more than 2 centimeters. Even if slightly more than 2 centimeters, it should be collapsible during a forced aspirations. In other words, any IVC that is more than 2.5 centimeter without aspirational collapse should raise the suspicions of right cardiac insufficiency. This would be a very nice article for you to go through at your free time, for you to understand about the variations of IVCs among the populations, depending on the subject, age, height, weight, BMI, and so on. Next, let's turn our attention to how to use ultrasound to perform the basic cardiac assessment on the patients. In practice, you can actually visualize the cardiac structures or the cardiac image through a few views. One of the commonest used views will be this, as illustrated in this video, which is a parasternal long axis view. Other views include subcostal view, parasternal short axis view, and also the apical four-chamber views. But in the interest of time, I think we will just focus on how to, interpret or how to understand the parasternal long axis view cardiac image. For the practical part, I suggest you to learn it hands-on from your senior or your attend courses. The main purpose of me putting up this video clip is to tell you that by just looking at the cardiac image of this video clip from the parasternal long axis view is enough to give you a wealth of information about the patient's cardiac functions. For instance, you can judge a patient's cardiac contractility or cardiac functions by looking at the ventricular volume as well as the ventricular wall contractions. It also allow you to visualize the aortic valve, the mitral valve, to see is there any pathology like prolapse, regurgitation, or sometimes you may even see vegetations, sitting on the valve. Also allow you to visualize the pericardium and also to decide whether patient got pericardial effusions or not. Regardless, like what I mentioned to you, most of the time in practice we will visualize the cardiac from definitely more than one views to ensure that we do not miss out any important pathologies. Last but not least, I would like to highlight to you about the clinical utility of bedside ultrasounds in managing patients with undifferentiated shocks. By definition, shock is defined as a circulatory failure that results in inadequate organ perfusions, and is often defined as a systolic blood pressure of less than 90 mmHg or mean arterial pressures of less than 65 mmHg with evidence of tissue hypoperfusions. It is beyond the scope of this video to talk about the details or the nitty-gritty about the emergency algorithm on how to manage patients using the POCUS guidance. But anyway, I must drive home that there's a type of shock known as obstructive shock. It can be caused by cardiac tamponade or it can be caused by massive PE. These type of patients, they are hemodynamically unstable, and the diagnosis of these two pathologies will hinge on your ultrasound findings. And also the treatments for these two pathologies are time sensitive. For example, for tamponade, you need an emergency pericardiocentesis. And for massive PE, you need a reperfusion therapy urgently. Most of the time, we'll give thrombolytic therapy. Patient stabilized already, only then we'll proceed with the confirmatory test, which is your CTPA. Thank you for watching until the end. I hope all of you have learned a thing or two about the use of ultrasound in clinical practice. Before I end, I must emphasize that even though ultrasound is an extension of healthcare, but it shouldn't replace your clinical judgment in the management of patients. The use of ultrasound is just served to give you more information for order for you to make better decisions. Thank you.